Good morning, Honorable Emeritus Chairperson, Swankar Sir, Pro VC, Dr. V.K. Kapoor Sir, esteemed Dr. Puvish Parekh Sir, Hemant Sir, senior faculty members, colleagues, and dear present students. Today, CCR will be presented by Dr. Richa Randhawa, a second-year resident from the Department of Palliative Medicine. Before that, I would like to give a short introduction of our department. Established in 2019, recognized by National Medical Council for MD program in 2021 with the annual intake of 3 seats. Our institute is North India's first private medical college to offer this course. Our department is one of the India's 8 exclusive centers offering this course. Our facilities include OPD chambers, inpatient wards, daycare facility, procedure room, and seminar room. Our OPD is situated in the upper basement of SRC buildings. The department offers academic programs to the students in the form of grand rounds, clinical case presentations, seminars, journal clubs, guest lectures, and CMEs. It is a matter of great pride that the European Society for Medical Oncology, that's ESMO, designated Shri Ram Cancer Center as a center for integrated oncology and palliative care services. It is amongst India's 5 recognized centers. I would like to express my gratitude to Dr. Hemant Malhotra sir for his efforts and guidance in getting this status. We follow ESMO guidelines for patient-centered care. These are recommendations integrating tumor-directed approach and patient-directed approach. Our center is also registered with Indian Association of Palliative Care. We provide services to the patients suffering from cancer, adults and children, and patients diagnosed with chronic and terminal conditions of various organ systems. We work together as a part of team in ICU to identify the futility of the management, to enhance the family communication, and to provide dignified end-of-life care. Pain management is another significant aspect of our department, which we will be discussing very shortly. We provide home care services to the patients whose families choose to care for them at homes. Our future plan includes a development of state-of-art hospice center, which is a center which provides compassionate care to the patient during their terminal stages of illnesses. For pain palliations, we are using opioid and non-opioid analgesic and performing various interventional pain procedures. Our faculty member, Dr. Nipun, has an expertise in doing various pain procedures. We are thankful to the management for making morphine available to our institute to help us relieve the patient pain. We are performing various invasive procedures like CM guided and USG guided intervention. Sphenopalatine ganglion block is very effective in patients with head and neck cancer, and trigger point injections help in relieving the pain of painful muscle conditions. Intravenous infusion of lignocaine is very effective for neuropathic pains. Our department is equipped with lymphopress, transcutaneous electric nerve stimulation, and ultrasonography machine. Our center has been recognized as a training center by Indian Association of Palliative Care for conducting certificate course in Essentials of Palliative Care. To date, over 25 healthcare professionals have successfully completed this course. Caregiver course is another training program for the individuals who provide care and support to the patient with the terminal illness. Till now, 6 participants have completed this course. Over the past 3 years, we have conducted CMEs, we have organized workshops, we have celebrated our World Hospice and Palliative Care Day, we have participated in community awareness program, and delivered online lecture series under the aegis of IAPC. Our events got coverage in media, and I extend my gratitude to Dr. Swankar sir for promoting and supporting palliative care services. We have 5 international and 10 national publications. We have authored 3 book chapters, received Doctor's Day Award on various occasions, and Dr. Richa, today's presenter, received award for poster presentation at international conference. I had a privilege to serve as an external examiner of palliative medicine at Gujarat Cancer Research Institute. So today we will be presenting our case, but I would like to make a small note that today's presentation will be slightly different. We will not be discussing the differentials or curative modalities, but we will be discussing how the palliative care was provided to our patient with advanced stage malignancy during his course of illness. As his illness advanced, his symptoms increased and his pain intensity increased. Pain is not just physical. It affects body and it affects other aspects of the patient as well as their family. It affects them psychologically, socially and spiritually. We would try to give an insight into these different aspects of the palliative care so that you can understand what actually palliative care is. Thank you. Now, since the case was first presented to the Department of Surgical Oncology, I would like to invite Dr. Prekshit to start the case. Thank you, sir.
Good morning, honorable dignitaries, esteemed faculty members and respected colleagues. Under the guidance of Professor Rajgovind Sharma and Professor Sanjay Sharma, I am Dr. Prekshit, Mch Resident. I'll be taking up the initial presentation of the case. So, a 42-year-old male who was a former driver by occupation, resident of Bassi in Rajasthan, from a lower socio-economical status is judged by the modified Kapuswamy classification, presented in February 2022 to the Department of Surgical Oncology with complaints of decreased mouth opening since a month and swelling over the right face since 10 days. The reduced mouth opening belonged to the Khanna and Andrade classification stage 3, which comprises of 15 to 25 mm distance. On past history, he was a hypertensive since 3 to 4 years on metoprolol 25 milligrams once a day. Rest of the medical and surgical histories were non-significant. He was a BD smoker of about a bundle a day for 20 years and was a tobacco chewer of 1 to 2 packets per day for 25 years. He was an occasional alcoholic, a vegetarian by diet with a normal bowel and bladder habits. The family history was not significant. On general systemic examination, all the parameters are normal except that the patient had a right cervical lymphadenopathy. On local examination, the patient had restricted mouth opening, inter-incisor distance of about less than 2 centimeters. On oral examination, he had a 4 by 5 centimeters ulceroproliferative growth over the right buccal mucosa, which was extending anteroposteriorly from the second incisor to the RMT, supero-inferiorly from the upper to the lower gingivo-buccal sulcus, mediolaterally from the alveolar erosion with orocutaneous fistula formation. On neck examination, he had a right cervical level 1B and level 2 lymphadenopathy. His routine biochemistry was altogether normal. So on a punch biopsy from the right buccal mucosa, it was suggestive of a moderately differentiated squamous cell carcinoma. And after a thorough staging workup for the patient, he was labeled as a head and neck squamous cell carcinoma, clinical stage of CT4A, N2C and M0. So this is a standard NCCN as prescribed by the NCCN guidelines that we follow. This is a TNM classification. A T4A stage signifies a locally advanced disease, and an N2C is suggestive of a clinical or radiological apparent bilateral neck nodes. So this case was discussed in the multidisciplinary tumor board, and the decision was made to offer a neoadjuvant chemotherapy followed by reassessment in lieu of the potentially curative disease. I'd like to hand over the case now to the Medical Oncology department to take it further. Thank you.
Thank you, Dr. Prekshit. I'm Dr. Chavi Goyal, a second-year DM Medical Oncology resident, and I would like to take the case further. So, as we discussed, 42-year-old male, known case of hypertension, chronic smoker and tobacco chewer, CA right buccal mucosa with a locally advanced disease. He was given neoadjuvant chemotherapy for 3 cycles every 21 days with docetaxel, cisplatin and 5-FU. This is the standard regime, and after this he was followed by re-evaluation. In re-evaluation, the size of primary lesion increased from 3.8 centimeters to 5.4 centimeters. Although the size of lymph nodes decreased, but overall it was a progressive disease, and after discussion in the multidisciplinary tumor board, the decision was made to offer him a concurrent chemoradiation with curative intent. So I would now like to call upon Dr. Mitwa, my radiation oncology colleague.
Thank you, Dr. Chavi ma'am. Good morning to all my faculty members, seniors and my colleagues. I am Dr. Mitwa Patel, second year MD resident in Radiation Oncology department. Now I will be presenting the radiation treatment part of this case. Patient was planned for the concurrent chemoradiation and total radiation dose was 70 gray in 35 fractionation, was delivered in 5 days per week over 7 weeks. In radiation treatment planning, first we prepare the thermoplastic mold, which is for the immobilization of the target area. In this case, we immobilization of the head and neck area so that radiation can be delivered in precise manner. Followed by the CT simulation of the patient was done. During the CT simulation, a scan was taken from the above head to below clavicle, and 3D images were generated and transferred to the variant server for the planning purposes. After computer-based planning was done for the target delineation. In computer-based planning, first we outlined the gross tumor volume. In gross tumor volume, we include all grossly visible and palpable disease. Then we create the clinical target volume. In clinical target volume, we include the GTV plus 0.5 to 1.5 centimeter margin for the cover the all microscopic area. And lastly, we create the planning treatment volume. In planning treatment volume, we include the clinical target volume plus 0.5 centimeter margin for the setup errors and patient movements. After completing the computer-based planning, plan optimization done by our medical physicist, and radiation was delivered by our linear accelerator machine. These two pictures are the LINIAC machine. And patient received the total dose of the 70 gray in 35 fractionation plus weekly concurrent cisplatin chemotherapy and completed from the 13th of May to 29th of June 2022. After first and second month follow-up, patient had no complaint and was asymptomatic. At 3 months follow-up, PET-CT was done, and which is suggestive of no new lesions, but lesions showing the post-radiation treatment effects. In first image, pre-chemo radiation, we can see the lesion 0.5 into 3.6 centimeter lesion involving the right upper alveolus and inferolateral border of the right maxilla. After post-chemo radiation, no new lesion, but lesion indicating the post-radiation treatment effects. After completing the chemo radiation, patient was cured of the disease and was apparently alright. At 6 months, patient presented with the fungating mass on the right side of the face along with the orocutaneous fistula, and CECT face and neck was done, which is suggestive of the 1.2 into 1.1 centimeter lesion is noted in the lower alveolus, infratemporal fossa, and ramus of the mandible on the right side with the bony destructive changes. It is more likely to the residual and recurrent growth along with the orocutaneous fistula formation in the right side. Now, this case is a very locally advanced disease, and it is inoperable case, and a patient presented with the orocutaneous fistula, which is contraindicated in radiation therapy because it increased the delay process of the fistula and also increase the necrosis around the normal tissue. Thank you. That's why we refer back to patient to the medical oncology department. Thank you. Now I would like to invite Dr. Chavi.
Since the patient had a recurrent disease after 6 months and radiation was recently offered and the patient was an unresectable case, so a palliative chemotherapy as second line option was given after discussion in a multidisciplinary tumor board, and a palliative chemotherapy with gemcitabine and carboplatin was given for every 21 days for 3 cycles. Unfortunately, the patient progressed on palliative chemotherapy also, and after 3 cycles there was disease progression. It was a chemo-resistant disease. So the patient was referred to Department of Palliative Care Medicine for further management. We can call it progressive disease, sir. Progressive disease. My bad, sir. I would now like to call Dr. Richa Randhawa from Department of Palliative Medicine.
Any role of immunotherapy in such patients?
There is a role of immunotherapy, sir. These tumors express the PD-L1 receptor to the tune of 80 to 90%, but it's an extremely expensive modality. It's not covered in the government insurance. So in our Chiranjeevi or the MA card, it is not covered, sir. So for the affording patients, we do give it a try, but for the non-affording patients, one cycle of treatment is about 2 lakhs of rupees, sir. One cycle of treatment. We need to give minimum 4 cycles before we can conclude whether the drug is working or not. If there is stabilization of disease or disease response, then we continue beyond 4 cycles also indefinitely till 2 years. So it is really truly expensive treatment.
Good morning, esteemed teachers, seniors, and my dear colleagues. My name is Dr. Richa Randhawa, second year PG resident from Department of Palliative Medicine. Now, palliative medicine works as an integral part of oncology team, and we have provided comprehensive support throughout the management journey of this case. Our commitment ensured that every facet of patient's care was meticulously considered and effectively addressed, fostering a holistic approach to the treatment journey of the patient. The patient came to the palliative medicine department with the chief complaints of pain over the right half of face for 7 days, diarrhea 5 days, and vomiting 3 days. Now, as we assessed the patient for the first time, we did his physical, psychological, social, emotional, and spiritual assessment of the patient. For pain, we used a numerical rating scale in which 0 means no pain, 1 to 3 is mild pain, 4 to 6 is moderate pain, and 7 to 9 is severe pain, and 10 is worst imaginable pain. Pain was gradual in onset, mild, continuous, aggravates with facial expressions, radiating to right ear, dull aching, did not affect the activities of daily living and sleep. And here the NRS score was 2 to 3. Then vomiting, 2 to 3 times per day, preceded with nausea, was yellow in color. Stools, 4 to 5 times per day for 5 days, brown in color, semi-liquid in consistency, not associated with blood or mucus. There was no history of fever, antibiotic usage, and laxatives. Now, coming to the Bristol stool chart, which is a medical tool developed in 1999 to classify human stools based on the categories based on their shape and consistency, in which type 1 and 2 is for constipation, 3 and 4 is ideal stools, and 5 to 7 is constipation. Yes, sir. And type 5, that is soft blobs where clear-cut edges were present, was in our patient. We used following assessment scales to evaluate our patient. First was Edmonton Symptom Assessment System. It's a widely used tool to assess the symptom burden in the patients, especially those which are suffering from advanced cancer. It includes pain, tiredness, drowsiness, nausea, appetite, shortness of breath, depression, anxiety, and well-being. in which 0 indicates there is no symptom and 10 is worst imaginable symptom. Second is ECOG performance status, which stands for Eastern Cooperative Oncology Group. It determines that how cancer is going to affect the life of the patient. It determines treatment and prognosis. It is going to describe the level of functioning of a patient in terms of their ability to perform their daily activities, walk and work. According to the American Society for Clinical Oncology, recommends against chemotherapy if ECOG score is greater than or equal to 3. Palliative Performance Scale. It's a tool which is used to assess the patient functional status and when to move towards end of life care. And hospice care is initiated when the patient score is going to be less than 70%. Palliative Prognostic Index. It's a tool which was invented in 1999 to predict the survival of terminally ill cancer patients, which was calculated by summing 5 independent predictable values, including palliative performance scale, oral intake, edema, dyspnea at rest, and delirium. If the survival is greater than 6, it was shorter than 3 weeks. Greater than 4, it was shorter than 6 weeks, and less than or equal to 4 was 6 weeks. In our patient, the ECOG was 1, PPS was 90%, and PPI was 1. Now coming to the psychosocial history of the patient. The household consists of his wife, which was described as a devoted and a supporting lady, though she harbors an ongoing fear of her husband's mortality, and son. Filial bond between son and the patient was considered as robust. His unemployment really raises concerns for him. He significantly feels anxious about the treatment options and is frustrated about inability to eat, hunger, ongoing pain, which requires frequent hospital admissions. There was a swelling on the face which led to body image problems like embarrassment, fear, low self-esteem, contributing to his denial, depression, and social isolation. This is a distress thermometer, which is a self-assessment tool in which 10 is extreme distress and 0 is no distress, and in our patient it was 5. This is a generalized anxiety disorder 7-item scale, which is a self-assessment tool which contains questions regarding frequency of anxiety symptoms over the past 2 weeks. And in our patient, it was 11, indicating moderate anxiety. Coming to the spiritual history. The individual embraces Hinduism, deeply identifying with its beliefs and practices, which holds very important part in his life. He ponders why God allows certain hardships. Yet, within this contemplation, he holds on to a sense of hope, seeking strength, deeper understanding in his journey.
Somebody who is not spiritual?
So spiritual is basically by self-evaluation, and religion...
An individual follows Hinduism and identifies as religious.
Sir, religion is what other people are going to tell you, and you have to, these are basic set of principles which you have to follow.
What I want to say
Yes,
is
sir.
that spiritual can be anybody, whether he's a
Yes, sir.
Hindu, Muslim,
Yes,
Isai,
sir.
or
Anybody can be
Buddha,
spiritual.
or anybody,
Yes,
yes.
sir. Then he actively participates in his religious community, finding solace and connection among like-minded individuals who share his beliefs. This was the tool which we used to assess the spirituality of the patient, that is faith and belief, and how important they are during this time of illness. Is he a part of any religious community, and how can we address this issue? Now, before moving to the treatment part, I would like to explain WHO analgesic ladder. This was invented in 1986 for cancer pain. Step 1 includes non-opioid analgesics, which is given with or without adjuvants. Adjuvants includes tricyclic antidepressants like amitriptyline and nortriptyline, anticonvulsants like gabapentin or pregabalin, biphosphonates, muscle relaxants like baclofenac, and steroids can also be given. Then step 2 is for moderate pain. We give weak opioids like tramadol and codeine with or without adjuvants. Step 3 is strong opioids like morphine, buprenorphine, fentanyl, which can be given along NSAIDs as well as adjuvants. So the patient was managed symptomatically by step 1, that is non-opioid analgesics, and other symptomatic management was given. Then in July 2022, post-radiotherapy, the patient came with pain on the right side of oral cavity, NRS was 2 to 3, and soreness. After oral examination, it was found to be mucositis. This mucositis can be very debilitating for the patient and leads to problems like eating, as well as difficulty in speech and to how to swallow. It also caused pain in the patient, which adversely affects quality of life of the patient. It usually occurs 6 to 7 cycles post radiotherapy and chemotherapy and lasts for 4 to 8 weeks. Oral care was advised, that is salt and soda mouthwash, oral topical lignocaine solution 6 hourly, multivitamins, proton pump inhibitors were given. And in our patient, it was grade 2 oral mucositis. Then in October 2022, pain aggravated and was accompanied with...
How the proton pump inhibitors will help in oral mucosa cancers or ulcers, sorry. Okay, take it.
Pain aggravated and was accompanied with stretching sensation. For this, we started the patient on step 2 weak opioids and other symptomatic management was given. In December 2022, patient came back with severe pain which was not relieved with step 2. So he was started on tablet morphine 5 milligrams 4 hourly and there was shortness of breath. His hemoglobin was 5.5 grams per deciliter and modified medical research council dyspnea grade was 3, that is he has to stop after 100 yards to take a breath. Blood transfusions were also carried out and other symptomatic management was done. Then in January 2023, patient came and he was not released with tablet morphine 5 milligrams as well as his hemoglobin was 6.2 and shortness of breath with grade 3. He was started on tablet morphine 10 milligrams which the dose was titrated, blood transfusions and other management was carried out. In February 2023, patient presented to the outpatient department reporting limited relief in pain despite of administration of 10 milligrams of morphine 4 hourly. In light of this situation, a decision was made to proceed with an interventional procedure, and the plan involved conducting a sphenopalatine ganglion block via transnasal route over 3 consecutive days. Now, SPG supplies sensory innervation to orbit, nose, buccal mucosa, palate, and paranasal sinuses. Plus, it also supplies autonomic innervation to lacrimal glands and inner lining of the nose, sinuses. Thus, it plays a vital role in many orofacial pains, like in our case of head and neck cancer. Other includes sphenopalatine neuralgia, idiopathic trigeminal neuralgia, headache, cluster headache and migraine, postherpetic neuralgia, atypical facial neuralgia. The patient is going to lie supine with the neck extended and 0.5 ml of 2% lignocaine solution is injected into each nostril and the patient is asked to sniff. Then a cotton-tipped applicator is inserted along the superior border of the middle turbinate and 1 ml of local anesthetic solution is injected into each nostril. Then we are going to leave it for 20 minutes. The patient experienced significant relief following the procedure as demonstrated in the histogram. There was a decrease in numerical rating scale from 5 to 1. And this was a study which was conducted in Mahatma Gandhi over 150 buccal mucosa cancer patients undergoing radiation. That transnasal sphenopalatine ganglion block was very effective in controlling pain.
Name of the journal?
Sir, Indian Journal of Palliative Medicine.
It's not mentioned here, no?
Okay, sir. Then in May 2023, patient presented with a large fungating mass with foul-smelling pus discharge as well as crawling sensation. On further evaluation, they were found to be maggots. Manual extraction of maggots was done along with triple therapy. Now, what is this triple therapy? Tablet ivermectin 12 milligrams per day for 3 days, which is a macrolide, which causes parasitic death and lead to spontaneous elimination of larvae. It is usually effective when surgical removal is unfeasible. Tablet albendazole 400 milligrams twice per day for 5 days. It's a broad spectrum anti-helminthic and anti-parasitic drug. Then clindamycin 300 milligrams per day for 5 days. Usually malignant wounds have anaerobic environment which causes bacterial infection, so it is quite effective. And this was a study which was published in Indian Journal of Palliative Medicine showing that triple therapy was very effective in malignant wound miasis. Now, these are the steps of manual extraction of maggots. As we can see in the image, it is absolutely heart-wrenching to see maggots in wounds, which can be deeply unsettling and elicit intense response, adding to the both visual and physical problems to both patient as well as for the family. The wound was first irrigated with turpentine oil once in a day. Then gauze piece soaked in diluted turpentine oil was inserted and left for 10 minutes. Wait for the larvae to come to the surface. Now remove the larvae with the help of forceps without its rupture, as it may cause foreign body reaction. Even dead larvae has to be removed because it is going to cause local inflammation as well as foreign body granulation formation. Keep the wounds dry, clean and covered. This is the challenging journey of the patient dealing with debilitating wound from 2022 to October 2024. In October 2022, the interincisional distance was 2 centimeters and there was an ulcero-proliferative growth which was involving the lower gingivo-buccal buccal suckers as well as alveolus, infiltrating the outer skin with 2 by 2 centimeters of orocutaneous fistula, exposed mandible and foul-smelling pus discharge. Then in December 2022, with the progression of the disease, the lesion extended to 5 to 4 centimeters orocutaneous fistula with foul-smelling pus discharge. Then in January 2023, there was again an orocutaneous fistula 2 by 1 centimeters in size just beside the previous one. Then in May 2023, there was a large wound with fungating mass, exposed mandible and orocutaneous fistula. Maggots was present and bleeding sites are also present. In October 2024, that is the most recent picture. This was a large lesion of 5 by 7 centimeters in size. Facial symmetry was distorted, torticollis was present, and the floor comprised of, in the upper part, there was an orocutaneous fistula 2 by 2 centimeters in size. Middle part consists of mandible and the lower granulation tissue, which was covered with foul-smelling pus discharge. The lesion extended from the second incisors to the retromolar trigone. Patient presented with shortness of breath, MMRC grade 4 for 1 day, that is 2 breathlessness to leave the house, episode of profuse bleeding during wound dressing, prompting emergency care. At this time, ECOG was 4, that is completely disabled. PPS was 30% and PPI was 7.5, that is expected survival of less than 3 weeks. Conservative management was carried out, and patient's relatives were properly counseled regarding the poor general condition of the patient, risk of further deterioration, futility of further management, and poor prognosis was also explained. They wanted to continue with life-saving measures. So, when we did evaluation, we found no underlying systemic cause for the bleeding, and surgical intervention was thought. So, at this point, I would like to invite Dr. Prekshit Chhaparwal to carry on with the emergency management of the patient.
So on a lighter note, the surgeon finally arrives. Challenges we faced were an ACS class 3 hemorrhagic shock. The patient was profusely bleeding. He was hemodynamically unstable. There was severe trismus of the oral cavity. Mouth opening was less than half a finger. There was severe dense fibrosis of the neck. You saw the large ulceration also over the neck. And because of the prior chemoradiation, so it became a challenging patient for us to establish the airway and also to achieve hemostasis. So we conducted a primary survey according to the standard ATLS and ACLS guidelines, and we found that the patient was hemodynamically unstable and had a threatened airway with a falling oxygen saturation. So we made a decision to ligate the bleeding vessel, surgically secure the airway, and also resuscitate the patient at the same time. So we followed what is called as ABC and also what is called as a CAB. Family counseling was done regarding the prognosis and a written informed consent was taken. So the patient was put in a supine position with neck extended using a shoulder roll. We prepped the patient with sterile painting and draping. A local anesthesia was infiltrated, and the tracheostomy tube was inspected for damages and balloon for competence as a standard protocol. So first, we had 2 simultaneous teams working side by side. A team was responsible for maintaining the circulation and vessel ligation, and the other team was busy securing the airway. So we applied the pressure over the bleeding site. The right sternocleidomastoid was retracted laterally. The internal jugular vein was identified and retracted using the vein loops, and the external carotid artery was identified. We clamped the artery and doubly ligated the external carotid, achieving hemostasis. Simultaneously, the team on the airway was securing the tracheostomy So we identified the thyroid cartilage to the sternal notch. We created a plane between the thyroid isthmus and trachea. The pretracheal fascia was identified and the tracheal position confirmed with the syringe. Transverse incision was given on the second and the third ring with a 11 number blade, and the tracheostomy dilator was used. We placed the tracheostomy tube in situ and the CO2 tidal volume was checked. You can see the post. That's the image of the patient post securing the airway and the circulation, resulting into a stoppage of the bleeding and hemodynamic improvement. The airway was secured and was connected to mechanical ventilation, and bilateral air entry was checked. The patient's vital parameters improved and he was shifted to ICU for further care. I'd like to call upon Richa to take on the case.
Now, after securing the circulation, airway and breathing, we continued with the subsequent management steps. That is palliation of pain, tablet morphine, diclofenac and paracetamol combination, gabapentin, baclofen was given, antibiotics. For anemia, blood transfusions were done. Now, management of fungating wounds. For bleeding, gentle removal of the dressing after soaking with normal saline. IV antifibrinolytics like tranexamic acid was given. Non-adherent dressing to maintain a moist environment. Cleansing by irrigation rather than swabbing. Now, management of malodor, which is the most distressing symptom in the patient who is having a malignant wound. It is going to initiate a gag reflex as well as vomiting in patient as well as the family members. So for this, tablet metronidazole 400 milligrams was crushed and applied topically over the wound site for 5 to 7 days. For infection, antibiotics were given. Patient comfort, that is by dressing and top packing was done. Psychological effects, that is address the issue, as well as dressing was done for the patient. Now, these are the steps of wound dressing. Now, challenge in this wound was extensive fibrosis, post-radiation, foul-smelling discharge, which was even unbearable for the patient, and disease-related infective wound. So, we removed the previous dressing by soaking it with normal saline and cleanse the surrounding area with the help of cleanse the surrounding area with normal saline and betadine and irrigate the wounds with normal saline and we did not swab the wound, and then put a moist gauze piece covering the whole wound and apply suction to the secretions, and then we again clean the wound. Okay. So these are the steps. We pack the wound with moist gauze piece, and this dressing was done by us only in the ICU. Then suction of any secretions were done and the wound was packed. Now coming to the tracheostomy care. First we are going to check the stoma. Is there any redness, swelling, secretion, any bleeding or any surrounding area? Then put the patient in Fowler's position, and then we are going to remove the soiled tracheostomy dressing, clean the flanges of the tube with a moist gauze and clean stoma with moist gauze and dry the stoma, replace the inner cannula, protect the skin with gauze pad cut in the middle, which can be placed between the outer tube and the skin. Careful suction has to be done, not more than 5 seconds, and be gentle. Do not do vigorously. Apply suction only when the secretions are audible and cover it with HME. Now, dietitian assistance was utilized, revealing a daily energy requirement of approximately 2000 kcal per day and 64 grams of protein per day. Psychological and spiritual support was given by active listening with an effective communication, in which you are going to carefully listen to what the speaker is going to say. Then also assess its emotional response without interruption, imposing opinion or passing any judgment. Active listening, key component is ask open-ended questions. Now take time to think what the information is given to you. Then ask questions, clarify those doubts and summarize in last. Respect his beliefs, offer comfort and support, address his spiritual concerns by daily allowing him to pray, and multiple counseling sessions were conducted. for home care. Education was provided regarding diagnosis, treatment options, encourage open-ended questions and signs to monitor. Training that how to do wound dressing was done. Then telecommunication, and this dressing was done by the patient's wife. Telecommunication counseling was provided, and multiple sessions of counseling for a sense of isolation, removal, as well as confidence and morale of the patient was done. Now, in managing this patient's care, our objective was to demonstrate the continuum of care throughout their treatment journey. It is important to note that over the past 1 year of management, the patient was not on any chemotherapy or radiation therapy. This approach allowed us enhancing the patient's quality of life and to address their comfort and support needs. Palliative care represents deeply human approach to medicine, recognizes that we are not just mere physical bodies. The smiles palliative care often brings come from deeper sources, that is from truly being seen, maintaining dignity, from connecting with loved ones, and from finding peace. This was the journey of the case with life-limiting illness, with tapestry woven of threads of physical pain, psychological distress, spiritual turmoil, and financial issues. On 25th October 2024, patient died with an acute episode of hemorrhage from the wound site and was brought dead from on the emergency. Then bereavement support was provided by contacting the bereaved person, active listening, encouraging expressions, and offering guidance and sending messages. These are some messages which we have sent them. Now I would like to address the significance of palliative care continuum, which is of paramount importance in this context. Healthcare providers often perceive that palliative care referral is appropriate only when the patient is dying. And this limitation excludes majority of those patients who are not dying but have poorly controlled symptoms and are in distress. This could lead to abrupt transition of care from curative to palliative. So, it is important to consider this WHO palliative care continuum, in which palliative care should be initiated soon as the diagnosis is made and should be continued along the curative treatment. Many studies have revealed that curative treatment along with the palliative care could prolong the life in some. And this care is extended to the patient as well as family during end-of-life phase, after death phase, that is the bereavement period. It's a period of grief. Now why this period? Because grief of losing someone is not a sign of disorder or weakness. It's an ocean of emotions, physical and spiritual necessity, ebbing in waves. Sometimes it's calm, sometimes it's overflowing. And the only way to grieve is to grieve with someone. Now, second image is of Dame Cicely Saunders, who started modern hospice movement and once stated very beautiful lines. You matter because you are. You matter to the end of life. We will do all we can, not only to help you die peacefully, but also to live peacefully until you die. So in a nutshell, palliative care is an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through prevention and relief of suffering by means of early identification, impeccable assessment, and treatment of pain and other problems like physical, psychological, and spiritual issues. So at last, I would like to extend my heartfelt thanks to esteemed teachers, my teammates, and dedicated oncology team, the management and the CCR review committee for their invaluable support and guidance. Thank you.